Without further ado, I want to introduce Ms. Molly Reeves. Molly is a nurse practitioner. She's a nurse practitioner at East Alabama Rheumatology Center, which is Dr. Adams' office. Molly received her Master's of Science of Nursing from Auburn, her nurse practitioner. She also received her Bachelor's of Nursing from UAB. Molly has worked with rheumatology since 2011. She began as Dr. Adams' infusion nurse, and now she's his nurse practitioner. Without further ado, we have Ms. Molly Reeves.
Thank you. So, yeah, like she said, I've been working with Dr. Adams for about 5-6 years, and when I was hired to be his infusion nurse, which was a really cruel joke because I did everything from infusions to prior authorizations to, direct patient care. So that was a trick, but I'm here now. So I started nursing school in 2008, went to UAB, had no idea anything about rheumatology or what I wanted to do. Worked for a while at UAB in the intensive care unit, the medical ICU, and then my husband's job transferred, so we moved here. And I did some home health nursing for a while. That was not for me. I thank any home health nurses out there because it's not for me. So I actually, I knew the manager at the orthopedic clinic from like years before, which is where Dr. Adams was working then, and he told me that they were looking for a nurse. So I basically was like, where do I sign? So I started, and we stayed there for a while. We had the opportunity to transfer over to the hospital, and that's where we are now at East Alabama Rheumatology Center I think we just had our 2nd birthday there. So our team was Dr. Adams and Rhonda, the physician's assistant, who many of you probably remember. She moved to Oklahoma, so now the new team is Dr. Adams and me and Joanna Stolga, the new physician's assistant we have over there. And if you haven't met her, you're going to love her. So anyway, nurse practitioner school, my specialty was family. So there was very little education about rheumatology, and I don't think that's very uncommon unless you specialize in rheumatology. It's kind of a gray area for most people. It's not as well studied as endocrinology or oncology, so that presents a lot of challenges in itself. So what is rheumatoid arthritis? It's a systemic inflammatory disorder. It's chronic and progressive, so it doesn't quit. It primarily targets the joints, but we know that it's systemic, so it can do a lot of things to your body other than your joints. We usually see it present with symmetric polyarthritis, so you're going to have involvement of joints symmetrically with inflammation, and usually starts in the small joints of your hands and feet. And often, I would go so far as to say we always see it present with other symptoms like fatigue, which fatigue is our arch nemesis. This is just a very brief breakdown of the pathophysiology of rheumatoid arthritis. Kind of hard to see it there, but what you see over here is a normal joint capsule. You see the synovial lining, the synovial membrane. It's just a nice, happy joint. The next two are joints that with rheumatoid arthritis, and this is an established patient with rheumatoid arthritis. And so what we see is an infiltration of T cells, B cells, neutrophils, angry inflammatory response that should not be there. And then in the established patient, we see kind of the damage that those cells have done. You have erosion of the joint capsule, the bone, the cartilage. So that's why we see a lot of hands that look like this. We have some synovitis in the MCPs here, which is what we often see. And then the ulnar deviation, which is where the fingers kind of turn. And this is what most of our young patients that come in are really concerned about. And rightfully so. I don't want these hands. Are my hands going to look like my grandmother's? Am I going to be able to button my shirt when I'm 60? And the answer is, this is not your grandmother's rheumatoid arthritis. We have a lot of new things, a lot of options, a lot of, treatment interventions that were not available, 20 and 30 years ago. So a lot of these patients come in so fearful that they're going to die in the fetal position because they can't move, just like they saw their grandmother or whoever. And it doesn't have to be like that. There are rare, severe cases where just, flat out nothing works. But for the most part, if we are aggressive enough with the disease and your body tolerates what we're trying to do, the hope is to prevent this. Here's another set of ugly hands. We see the swan neck deformity here that's kind of classic. This man in particular, he needs help with his everyday activities. Brushing his teeth is probably a challenge. Buttoning his shirt, just everyday hygiene kind of things are a challenge. So it's so important that these patients seek care early, because this can be prevented, hopefully. So what are the goals of treatment for rheumatoid arthritis? We want low disease activity. We really want remission. We want to control the swelling in the joints, and we want to ultimately prevent damage of the joints. We want to keep our patients going. People with rheumatoid arthritis have families, have jobs. They want to enjoy their weekends. They have hobbies. They want to crochet. They just like everybody else, and they just have this limitation, and we don't want them to be limited. Disability is a major issue for patients with rheumatoid arthritis. So many patients end up having to go on disability, and we don't want that. I mean, if you've checked, disability is, I don't know how people live on it. So we want to keep you at your job. We want to keep you functioning. And of course, we want to control your pain and stiffness. Those are our two biggest complaints. I'll go back and mention, these new younger patients that come in who are like, what's going on with my body, who are diagnosed with rheumatoid arthritis. It's always an eye-opener for me to hear people say, and I hear it all the time, I just thought everybody hurt when they woke up in the mornings. Somebody understands that. I hear some moans and groans. I just thought that was aren't you stiff for an hour or two when you wake up? No, I'm not. You shouldn't be. We don't, so we want to keep that from being your normal. I'm so off track. I brought goodies and stuff. How we choose to treat your rheumatoid arthritis depends on a lot of things. It depends on, do you have comorbidities? Do your kidneys work the way they should? Does your liver work the way it should? That's going to change what we prescribe. Do you drink alcohol? There's, one drug in particular that you can't have with alcohol. And that's okay. We just choose a different one. Have you already kind of been on this roller coaster of trying all these different drugs for your rheumatoid arthritis? How'd you respond to those? That can kind of push us into a certain direction for your next treatment. And also, we have to remember to be sympathetic to these patients, because this is a disease that's not going to go away. It's not going to be cured. We want to manage it, we want to control it, but we can't cure it. So we have to remember that the treatment regimen that we think is best for the patient, is it really? If we want you to be on a monthly infusion, is your job going to allow you to be off half a day to come and sit in an infusion room once a month? Are you going to be able to come every few months to have your labs done if we put you on these certain drugs that are going to require that? And it's so easy to sit on the other side of that fence and think, this is what you need, make it work, this is going to be the best for you. Well, do you have childcare? Do you have, we have to remember that this isn't my disease, this is your disease, and we need to form our treatment around what works best in your personal life. So what are the common drugs that we use in rheumatology? Of course, we use non-steroidal anti-inflammatory drugs, NSAIDs, and you see your Aleve over the counter, your ibuprofen. We can do prescriptions of those. We have Celebrex, Meloxicam. I'm sure you've seen a lot of commercials on a lot of these drugs I'm about to mention. Steroids, particularly prednisone. We hate it because it works so well. Somebody understands that too. When we put patients on prednisone, it's usually because they're in a flare, they're in an exacerbation of their disease. It's like, I can't get up, I can't, wipe my tail, I can't go to work, I can't lift my elbows, won't let me lift my toddler. So that is a very appropriate time to use steroids. We like to keep steroids reserved for only those times. We don't want patients on long-term steroids. There's so many long-term side effects, diabetes, osteoporosis, infection, things that we really don't want to, you got enough going on. But they do work so well that sometimes it's hard to get patients off of them. They're like, leave me, I feel good, I'm functioning, my joints bend. So that's steroids are tough, but I always try to remind patients, think about yourself in 20 years. Let's figure out another way for now. So we have disease-modifying antirheumatic drugs. We call these DMARDs. And we're kind of getting into the bigger guns of treating RA here. We have methotrexate, sulfasalazine, azathioprine or Imuran, leflunomide or Areva, hydroxychloroquine or Plaquenil, and Cellcept. And these are drugs that we use pretty commonly. Methotrexate is our pretty much our standard of care go-to for RA, for patients that need to start a DMARD. Methotrexate is taken once a week, and imagine all the ways you can take a medicine, and these are the ways you can take methotrexate. You can pills, in subcutaneous injections, muscular injections. You can literally drink it. So there's lots of ways to do this. Some people on methotrexate, it hurts their stomachs, so these are the patients that we will change to injections of it, and this starts patients kind of getting used to self-injections, which is something that people without these types of diseases, unless you have diabetes or something, really never have to think about. I don't want to give myself a shot. I'll give any of you a shot, but I don't want to do it to myself. So there's another kind of mental hurdle that these people have to jump over. We have to monitor labs for these, sometimes a little more frequently in the beginning with certain drugs, but any of our patients on any of these drugs, with the exception of Plaquenil or hydroxychloroquine, we need to see lab work on you every 3 months at least. We want to make sure that we're not poisoning your liver and your kidneys, and most of the time we're not. If we get a high liver value back, we may decrease your dose. We may take you off of it for 2 weeks and put you back on it, and then you're fine. But it's just something that it's important that we keep a close watch on. And here are our big guns in rheumatology for rheumatoid arthritis. These are the biologics, and these are probably some that you've seen a lot of commercials and things about on TV. We have Humira, Enbrel, Cimzia, Remicade, Simponi. Those are all anti-TNF alpha drugs, and then the drugs with different mechanisms of action besides TNF blockers are Actemra, Rituxan, Xeljanz, Orencia, and Kineret. Let me grab my notes. So I brought some like little auto injector kind of things to show you how some of these drugs work, and I'll just kind of let you guys pass them around. Play with them; they're kind of fun. This one doesn't have a name on it, but this is what the self-injectable Actemra injection looks like. And most of them you can actually pop them like you're injecting, and then you can reset it. She's also handing out some adaptive devices that I'll talk about in just a second. So all of these drugs are either injected or infused through an IV. Some have both options. So we work really closely with our infusion center, the cancer center at EAMC, and we have tons of patients who go over there for IV infusions, and this process is a little more near and dear to my heart because I did infusions for 4 years with Dr. Adams before we stopped. As a patient, you really kind of get to know your infusion nurse, and as a nurse, you really start to have a soft spot in your heart for that patient that you're seeing every month or 2 months or however often. Because you're sitting there together for a couple hours usually. A lot of, I won't say a lot of the time, most of the time, in choosing which drug is best for the patient, it's going to depend on what have they already tried and failed, so we need to move forward. And also, what does their insurance company want them to take? And I will not bore you with how miserable insurance companies are trying to make us and you, but truly it's, even if we think, oh, this patient, for whatever reason might do better on, Actemra or whatever, their insurance company is going to make them try and fail Humira and Enbrel first, usually. A lot of patients are like, I don't want to inject myself. I can't inject myself. But they have to figure something out, usually, whether it's a neighbor or a sister or whoever can do it for them, because oftentimes we have to jump through that hoop before we can actually get on infusible drugs. Not to say that infusible drugs are better than injectable. We have the same goal with all of them. They just work a little differently. And if you guys have any questions about the things that are going around, just ask me. Patients often are kind of perplexed about the self-injection portion of it. Where do I inject? How do I inject? Most injections are given in the thighs and in the belly. They just go right under the skin into the little fatty layer. So it's not this huge needle that you're having to stab in yourself. And most of the injectable drugs that we do come with an auto-injector. So if you're like me and you have an aversion to needles, unless I'm putting them in someone else, then you don't even ever have to see it. It's designed where you can, press on your skin and then pop a button and it does the work for you. You don't have to see the needle. It's not as, once patients do it 1 or 2 times, they usually will say, that's not as bad as I thought it was going to be. Some of the solutions burn a little more than other solutions. Some of these injections you take one a week, some every couple weeks. It's variable. Same with the infusions. Actemra is infused once a month, but Actemra can also be given as an injection, depending on what your insurance is going to help you out with more. Rituxan can be infused 2 times in 2 weeks, and then you don't get it again for another 6 months. Xeljanz is was our first biologic that's actually a pill. They started with where you take 1 pill twice a day, but they've come out with a new extended release Xeljanz, so you actually only have to take 1 pill a day. So there's a lot of patients who are very happy about that. It's commonplace for us to combine DMARDs like methotrexate, sulfasalazine, and if you're getting some relief from what we're doing, but you're really not where you want to be, you're not where we want you to be, we'll add another one on. If you're not getting any relief whatsoever, we're going to take you off of that one and start new with something different. But it's normal for us to put patients on 2 or even 3 DMARDs at a time. There have been some studies that show that methotrexate, sulfasalazine, and plaquenil together, it's called Odell's protocol, actually can be as effective as some TNF-alpha inhibitors with symptom management. But in the end, they found that it really wasn't as effective with radiographic imaging. So damage still was being done. But for patients who don't do well in biologics or who don't want to do it, that's an alternative. And then often we will combine DMARDs and biologics. I would say it's rare for us to have a patient on a biologic that's not also on a DMARD. And there's some that just kind of go together well, like Remicade is an infusion, an IV infusion, and we always try to have patients on methotrexate if they're taking Remicade. So it's kind of like putting a puzzle together, figuring out what works best for this individual, and also what drugs work best together. So as far as other treatment modalities, we do a lot of physical therapy referrals, occupational therapy, and we really encourage exercise. Water aerobics is about the best that you can get for rheumatoid arthritis. There's not as much pressure on your joints. You're freely moving in the water and walking. Things like running, high impact exercise is not a great idea. We want to preserve your joints. And just weight management is a huge deal too, because as much pressure as you can take off, I can't remember exactly how this works, but there's for every pound you lose, you take a certain amount of pressure, and it's a large amount of pressure off each knee. Just with if you lose 3 or 4 pounds, it can make a significant difference in your knees. So glucocorticoid injections are something that we frequently do into the joints. So this is, when you come in and you need an injection in your knee or an injection in your elbow or whatever, you're getting steroids. We mix a numbing medication in with the steroid. And we try to reserve this for when, this one certain joint is just plaguing me. I've been dealing with this for weeks. Had a lady this morning came in and it was her shoulder. She's done physical therapy, she's stretching, she's taking her medication, but for whatever reason, rheumatoid arthritis will not let go of that shoulder. So, in those situations, it's a good treatment idea to inject it with a steroid. We tell patients that, because they always want to know, well, how long is this going to last? We want certainty. What's this going to do for me? And Dr. Adams will tell patients that these shots work in 3s. If it works for 3 days, then really we didn't do anything for you. It's just a numbing medicine. We just numbed you up for 3 days. If it works for 3 weeks, then yeah, you probably got some benefit from the steroid itself. But what we hope is that it works for about 3 months, and you don't have to deal with that joint nagging you for a while. Sometimes we have patients that come in this situation, we'll inject their joint, and really that joint doesn't bother them again for, a long time. Is every other joint bothering them? Maybe, at some point or another. We'll also do just regular, just intramuscular injections of steroids. This works better, we find, for patients who are having just every joint hurts. Like, there's not a joint you could mention that is not on fire right now. So we'll do a systemic injection through the muscle, and it kind of will quieten everything down. We try to avoid this for the same reason that we try to avoid oral steroids, long-term side effects. But like I said, if you're not functioning, we don't really have a lot of choice. And some patients do better with injections than they do with just oral prednisone. Everybody's a little different. So what we need to consider with rheumatoid arthritis is that joints affected by RA, it can be irreversible, and joints can be destroyed if we don't control the inflammation. So how do we prevent this joint damage? We need to promptly diagnose. We need to recognize how high the disease activity is early, and we need to quickly achieve and maintain control of the inflammation. It's really important that we treat aggressively early, because most of the damage done with rheumatoid arthritis is done in the first year or two. So that's when we really need to be aggressive. So this is a very strong recommendation in rheumatology now, that all patients diagnosed with rheumatoid arthritis should be started on DMARD therapy as soon as possible following diagnosis. This has shown much better outcomes for patients in the long run. Just using, a prescription anti-inflammatory, just using steroids, you may feel better, but the joint damage is still occurring. This is why we need to start treating with DMARDs, like the Methotrexate, sulfasalazine, Imuran, Cellcept, those drugs. And of course, using the NSAIDs and the intermittent steroids, that might be your perfect recipe, a DMARD and an NSAID. But it's just important to get you on the DMARD as soon as possible after diagnosis. And, these drugs are scary. You go and you read about them and you think, I'll take my joint pain. But, really, if you're being monitored closely, which is what we aim to do, and everybody's on the same page and everybody's communicating well about how are you, how do you feel? If we put you on a drug and you feel worse than you did off of it, we don't want you on it either. We'll find something else. But it's important to be educated as a patient. It's important to read about the medications that you're taking and the choices that you together are making with your provider about how we're going to manage this disease. And it's also important that you trust. We don't want any of our patients doing anything that they are not comfortable with. If you read about this drug and you're like, no way, I don't get a good feeling about this, well, we don't have a good feeling about it either, But our ultimate goal is to keep your disease in control for the long term, and while keeping you safe. So Arthritis Foundation of Alabama is a good resource for patients with rheumatoid arthritis. I have the website here if anybody wants to check it out. Sometimes there's they'll have things like an arthritis walk or whatever that you may want to participate in. And my resources today came from the American College of Rheumatology, Up to Date, and Rheumatology.com. That's really all I have for you guys today. Thank you for listening so attentively. I hope you guys enjoy the rest of your day.
Do we have any questions for Ms. Molly today?
Yeah. So infusion means to get an IV. So patients will go to the infusion center, and a nurse will start an IV, and the pharmacy, and so the patient gets a little bit of fluids before the actual medication comes from the pharmacy, and then depending on what medication they're getting, you might be there for 30 minutes with this certain medication. You might be there for 3 hours with this certain medication. So it's really all specific to the medication that's being infused. But while you're there, while your infusion's going, there you have a team of nurses around you, monitoring you, making sure that vital signs are good and that you feel good and you're comfortable. They even bring snacks and things like that. Do you have any more did I answer your question, or okay? Yes, sir.
Are you still doing infusions, or are there other infusions in the area?
I don't do infusions anymore. When I first started working with Dr. Adams, I had this tiny little bitty infusion room with 3 chairs, and I was the only infusion nurse, and I just kind of kept them full and rotating. Now we use the cancer center over across the street at the hospital, which is really convenient for us and for our patients, because it's a short walk down the hallway from our office. And then we do have patients who are not from this area who receive infusions from other hospitals. We have a couple in Montgomery, a couple in Columbus, and so we'll work with work with the patient wherever they are.
So there's no private infusion center in the
No, there's not.
What about home infusions?
Home infusions are an option. That can be challenging. But yeah, we do have a few patients that get infused at home through like a home health agency. Certain drugs that we frequently infuse, they won't do it. Like in-home infusion companies don't want to do it because they don't want patients to have a reaction in the home, or there's certain precautions that have to be taken with certain drugs. So it's a very, very small percentage of our patients who are actually infused in the home. Yes, sir.
Just one last question.
Yeah, go ahead.
The infusion
I
center.
got all day.
Okay, the infusion center. What's the risk factor of why the rheumatology practice is not having conducting the infusion inside of the clinic?
Because it's so convenient and perfectly set up that we're just right here next door to this already established infusion center. So they take all of our patients. And we're within East Alabama Rheumatology. East Alabama Rheumatology Center is part of East Alabama Medical Center, and so there's just really not a need to have a separate one at this point. Now, if we get another physician and a couple other physician extenders, and our infusion load just quadruples, that may be something we explore in the future. But we have such a good working relationship; it just works well the way that this is the way we have it set up now. So I don't know if that answered your question, but maybe I don't even have the answer to that question.
The only reason I'm saying that is because a lot of the individuals do not go to the cancer center that we found.
Right.
And then in the physician office or
It's a little more
the
comfortable,
infusion center, they find it to be more convenient because they're familiar with people instead of
That's
an
true.
open environment with all these strangers.
You're exactly right. It was a really tough, transition for a lot of my infusion patients to go from my little bitty room to the cancer center. They didn't want to do it. But the truth is, the nurses over there you're not going to find any better. And they have developed relationships with them just like they did with me. They developed trust. They've developed a comfort there. So it's scary to think about going to the cancer center to begin with, but our patients generally like it over there. They like their nurses. They like the care that they receive there. So.
But East Alabama does have another separate infusion room from the cancer center.
There isn't there's kind of a little separation. They're all under the same.
Right.
But it's and a lot of patients like to be in there because it is a little smaller. That's Brandy, the infusion nurse. She's wonderful. She infuses certain drugs, and then the big infusion center infuses certain drugs. So it just kind of depends on what you're getting as to which room you go in. Yeah. You lied.
I'm concerned about this. We have, I know like medicine is moving towards infusion.
Mm-hmm.
So we know it's going to be a higher percentage now.
Well, not necessarily. Not necessarily. There's still great injectable drugs out there, and more, that's not going to fizzle out. But go ahead.
How many patients you think you have that is on infusion in your practice?
Why would you ask me that? Dozens?
Roughly.
Dozens, maybe. I don't do the infusion orders anymore, so it's hard for me to recall. Maybe 20 a week go over for infusions. And, it can, some weeks maybe less, some maybe more. So we have several infusion patients.
The reason why I say now, the practice that we used to be involved in,
Mm-hmm.
I mean, we had hundreds of people going into that area. Because we were dealing with osteoporosis as well.
Right.
And other, diseases.
Mm-hmm. And we do too.
It was a high volume.
We send patients over for reclass for osteoporosis. We do our own Prolia injections. We don't send them to the infusion center. But it works. I mean, it's a really large infusion suite. They're very well staffed. They've kind of got it figured out. Yeah. Any other questions? All right.
Ms. Molly, we want to thank you from the Destination Divas,
I'm gonna have to do this.
Eminent Solution, and New Thing Empowerment. We want to thank you so much for
much.
coming to do a presentation. Thank
You shouldn't have done it, but thank you.